having to restart it again. It just stopped on me, but go ahead.
Okay.
Okay, go ahead.
So when we look at the biomedical model of pain, that means that we have treated pain with drugs, surgery, and injections. And for acute pain, those things actually work. For chronic pain, we know those things don't work actually. And not only do we have a plethora of research, not only does my book talk about it, but coincidentally, the NIH and the CDC came out with statements about 6 months ago because of our opioid epidemic saying, you know, opioids are not the fix for pain, and we need to start to look towards the more natural strategies. The paradigm we need to move toward is what's called a biopsychosocial paradigm. So that looks at the body, the structure of the body, the biochemistry of the body, but the psychosocial aspect also looks at the brain, how the brain is processing certain information, and is it causing pain as an output? So an output means, and we can talk about this a little bit also, it'll be helpful for people. There's something called the bottom-up approach to pain, which is, okay, I sprain my arm, and the signal is being sent up to my brain, and my brain decides to make pain.
Okay.
Or there's the top-down approach, where for some reason, there's something going on in my brain, i.e. my thoughts, my memories, my emotions, that is causing pain as an output, and that's the top-down approach.
Okay, yep, that makes sense. That makes sense. So just for, you know, I actually just kind of spurred up a thought in my mind about it when you said that. Is that one reason why maybe it's the top-down approach, that EMDR, you know, eye movement and sensitization is effective for people because it's changing the memories in the brain? It's effective for people with pain. Is that similar? Does that make sense from the top down, right?
Makes perfect sense. What that technique does is it kind of disrupts some of the pathways that you developed in the brain. So pain is both a sensory and an emotional experience. So the sensory part is what's coming into the brain. So we need to look at all of our senses. So what you're feeling in your joints, the biochemistry in your body, the information that's coming in through your eyes, your ears, your nose, your mouth, all 5 of your senses. All of that is taken into consideration when your brain either decides to make pain or not make pain. Because ultimately your brain, no matter what pain you have, whether it's an acute injury, whether it's autoimmune disease, no matter what pain you have, the brain ultimately makes the decision whether or not you have pain. Okay. And that's a huge leap for people. And a lot of people are probably saying, that sounds interesting, but what does that really mean? I don't quite understand that. So we can talk more around that a little bit.
Okay. Yeah. Let's go into it. I mean, that it's something definitely that I'm like, how do we go from there then? How are we deciding to make pain? You know, let's talk about that.
So your brain basically weighs the world, and it looks at signs of safety in your life, or what I call the SOS signs, or signs of danger. So the signs of danger signs are things that we want to talk about first. So that is, what are your thought patterns basically? And I talk about pain catastrophizing in my book. So pain catastrophizing are the thoughts of, I'm always going to have this pain. My pain's never going to go away. This pain is going to be the death of me. My pain interferes with everything. It disrupts my entire life. So negative thoughts breed negative thoughts. And being catastrophizing or having those thoughts has been shown to actually increase the intensity of your pain or increase the duration of your pain, no matter what your pain is. So first, looking at those thoughts is a way to decrease your pain, basically. And I have some simple tools that people use to, measure their own pain catastrophizing thoughts and see if they really need to work on that.
Oh, I completely, that resonates with me on such a high level. It truly does. When you go from being a very active, vibrant, healthy person, and all of a sudden you're like, where is this coming from? You can really go down a rabbit hole with your thoughts. And catastrophizing is a word that I use when I talk to my coaches too, is that we have to change our mind about many things in our lives. And pain is one of the ones that was the hardest for me. I would literally write in a dry erase marker on the mirror, I am pain-free. Today I feel, this or that, just to try and get myself triggered up to a different habit in my mind. So give us like 2 of your top tips for something like that.
Well, the first is take the questionnaire and figure out if you have pain catastrophizing thoughts. And the second is you have to become mindful. So you have to kind of pause throughout your day and check in with your thoughts and see what they are. And then once you check in with your thoughts and you start to either journal or write them down or just, mentally file them, then you have to actually replace that thought with something else, basically.
Yeah.
And that something else is really important, because the truth is metaphors, and I talk about metaphors a lot in my book. If you can replace it with healthy metaphors, so you replace your thoughts with healthy metaphors, it really starts to reshape what's going on in your brain. So some of those metaphors, let's talk about them for a minute. So some of the negative metaphors that people often have in their brain are, I have arthritis because I have wear and tear on my joints.
Yes, I've heard that.
And the truth is the human skeleton is an incredible feat of nature and can take a lot more quote unquote wear and tear than you actually think it can. So that's a big one that people come with. And a lot of these are around the myths of pain. The other myth is, some of these myths and metaphors are, if I'm injured, I should stop moving.
That was one of the things I was going to ask you about. Go ahead. Yes.
And I always tell people, movement is medicine and motion is lotion for your joints and your body.
Oh, I love that.
Look at movement in that way. When it comes time to looking at x-rays, we know that x-rays and imaging studies poorly correlate with people's reports of pain. Okay,
that's a great place that I want to interrupt you for a moment and ask you. I remember years ago reading this. This was something that was very powerful for me too. I read that the majority of people who have had these x-rays, it was a study of some sort, showed lots of arthritis in their spine. This is the elderly population, but never experienced pain. But their x-rays, their MRIs, all of their, those imaging studies showed significant degeneration, but yet they experienced no pain. And then they contrasted that with people who had chronic pain, who had very little, if any, degenerative problems in their joints, but were in extreme pain and pointed to the joints as a place of pain. I don't remember which study that was, but I know you're nodding your head because you remember something like that, right? Can you talk about that a little bit?
Sure. I mean, if your tribe wants a study and they like to read studies, there was a great systemic meta-analysis done. So a meta-analysis is when someone goes into the research and pulls thousands of research papers on a certain topic. And we have wonderful research on the spine because we have a plethora of spinal pain in our society. And they looked at 3,300 people in this study. 3,300 people is a huge study.
Yes.
And what it showed was, of course, as you got older, there were signs, quote unquote, signs of degeneration in your joints. But the vast majority of people in the study who had that degeneration had no pain or had very, very little pain. So back to that biomedical model, there are certain practitioners out there, physicians, of course, that they rely on the x-ray or on the MRI only and make their entire decision for someone's pain rehab or someone's pain care based on that study or based on that image. And I always tell people that, imaging can cause harm. And when I say that, I don't mean that it's going to cause physical harm to you. But when that person you go to in the white coat that you trust and has the big initials after their name holds up that x-ray and says, "Oh, wow, look at your right knee. It's got arthritis in it." And they say, we're going to do a total knee replacement or arthroscopic surgery, whatever it is. That starts to wind up your brain and wind up your nervous system. And some people more than others, we don't know why this happens. And ultimately, it turns on that harm alarm and causes fear. When you turn on that harm alarm and there's fear, your brain automatically starts to create pain as that output.
Oh, I believe that.
So that imaging study is a really small part of looking at your overall pain experience. To answer your question, sometimes I go off on a tangent about things, but hopefully that answers the question about, and we also, here's the other way we know this, is that each year we do about 800,000 spine procedures, whether it's a fusion, whether it's a microdiscectomy, putting cages and rods, and now we're putting in we're inserting, new discs into people's spines. And within 2 to 5 years, most of those patients return back to the same exact pain levels they had before the surgery, and sometimes even worse.
Yes.
So we know that it's not working.
I agree. And I actually, I wrote a guide on the thyroid, and in that guide, I talk about how doctors will pull up their labs and they'll hold it out to the client and say, look, everything's fine. Your TSH is normal. And yet the client or the patient is sitting there with every symptom of thyroid disease. And I call it the paper versus the person syndrome, where the paper is more important than the actual person and how they feel and what they're saying. They know themselves, but then a doctor can show them something, and all of a sudden that mindset starts to shift, and they start to think, well, maybe I am fine. Maybe it is all in my head. It's very damaging. That kind of language is very damaging to a patient. Personally, it happened to me many, many, many times. And I was assertive enough to walk forward and not look back at that. But many people are not. They're not. So, yeah.
So let me touch on 2 points about that, because it's really important, because everyone probably has had something x-rayed at some point, or maybe they have pain right now. So as far as x-rays go and your joints, we grow like trees. So some of our limbs are a little bit longer and maybe a little more beat up, and others are, kind of less beat up. And the interesting thing, where if you go to a practitioner and they say, okay, this is the cause of your pain, I would always ask them to say, wow, how many people my age actually have these types of changes in their back or their neck or their knee? And could this be the only cause of my pain? Is this the only thing that causes pain, basically? The other really interesting thing to keep in mind, and I'm not against physicians or the medical system. The average, when I did research for my book, because I was so fascinated by some of this, because I've worked with physicians my entire life, and some of them are my good friends. The average physician receives 4 hours of what's called pain science education in their medical training. So in their 4 years of medical school and their residency, they only receive 4 hours of pain science education. Most of the education they receive about pain is what surgery should we do and what medication should we prescribe. So they're not thinking or looking at the brain, stress, your emotions, your thoughts, what you've been told about pain. What did your parents tell you about pain? What are the thoughts that you hold on to that you believe? Do you believe that, women are not as strong as men, shouldn't exercise, or should not be as mobile or physical? Did your mother have back pain and you feel like it was passed down to you? All these things really weigh in. All these memories are like little files in your brain. So when you go through a pain experience, all these things come into play, and you have to start to break them down. Once you really break them down, then you can start to kind of repattern what's happening in your nervous system and in your brain and your body.
Yeah, that's great. And I think, let me ask you this. Is it true that pain can be stored from ancestors down? Like, say you have a grandmother that had, chronic back pain, and then your mother, and then all of a sudden it becomes a genetic belief. Oh, it's in my genes to have back pain. It's in my genes to have heart problems. I don't believe that. I believe it takes a trigger or an expression to express that gene somehow. But tell me what you think about that. What's your experience with that thought process?
We've just started to scratch the surface as far as how genes contribute to pain. And really we're looking more at why people develop things like chronic regional pain syndrome, which is a very awful pain syndrome. Those are the places we're kind of looking first. The type what you're talking about really is more how your beliefs, what you've been taught, what you've been told, really affects you. And the thing is, Carmen, is what's fascinating about this is that most of this happens subconsciously. So all this is happening at light speed in your brain, and you're not thinking, oh, what did my mom tell me when I was 14 years old about pain? No one thinks that. It just, boom, it comes in your head. And some of these are myths that we hold on to. And some of them are just things that we pick up from the internet or from friends or from practitioners who, don't really understand, pain fully.
Yeah.
If you look at kind of pain in our country, in the United States, we have about 100 million people who struggle with chronic pain.
Wow.
About 50 of those 100 million have a clear autoimmune cause, autoimmune syndrome, which is inflammatory. The other part who don't have a chronic inflammatory syndrome, and they're out there, I see them all the time. I had a patient who just came into me a couple of days ago, perfect diet, takes care of herself, but she's had chronic pain for many, many years. So for those people, we need to look at the brain. And what's really interesting is in some people, we need to look at all of it. So if you've had rheumatoid arthritis for 10 years and you have the inflammatory component that's going on, plus you have all the central changes. So central is the brain and spinal cord that are happening. Then we need to look at everything and just treating one thing. And that's why a lot of patients come to me and I say, have you tried diet? They say, yeah, I've tried. I've been on the FODMAP diet. I've been on this elimination diet, that elimination diet. And I say, well, how did you do? And they say, well, it helped. It actually took away my pain up to a certain point.
Right.
And I say, okay, that's wonderful. It either tells me that, one, we need to go a little bit deeper, or two, your pain is not inflammatory. Your pain is coming from that central place. And you really have to know how, when you work with people who have pain, you have to know what to look for, how to evaluate them, the right questions to ask, the right tools and resources to use during your evaluation, your assessment, which starts to point you in the direction of, okay, well, this person, they have no sugar in their diet. Okay, maybe they're having a little bit of cheese every couple of days, but they're relatively gluten-free. But when I look at some other things, like their pain catastrophizing thoughts, some of the things they believe in, their stress levels, it points me to a different direction.
Okay. So interesting, because when I was in my process of trying to figure it all out, the chronic pain thing, like, why is this happening? Where is this coming from? I have an example of one day I was just walking through the kitchen, and I felt and heard my toe make this loud snapping noise. And the next thing I knew, I couldn't step on it, right? I thought, what in the world? I was walking. You don't break your toe just walking unless something's really wrong with you, right? I let it go for a week where I just walked differently. I focused on it so much. I finally was like, fine, I'll go get an x-ray. It's been a week. And my doctor he's awesome, and I'm still with him today if I ever need anything. But he said to me, Carmen, it's just inflammation. And I said, what do you mean? He said, you have autoimmunity. It's just inflammation. It's not broken. There's nothing seriously wrong with you. And you know that I walked out of his office with no pain in my toe, and it never came back.
Yeah. So what he did was he decreased the fear that you had. And when you decrease fear, you decrease pain. And for some people, it can happen rapidly. I have a friend of mine who's a functional medicine physician here in New York City. And he went away for a weekend trip, and he got home and he said, I've had this back pain for like 4 days, and I wasn't going to contact you, but I took 4 Advil. This is a functional medicine physician. He's like, I took 4 Advil and I noticed absolutely no difference. He's like, so I'm thinking it's not inflammation. He's like, what else could it be? And I said, why don't you come in and let's talk through this a little bit. And within an hour, we talked through it. I gave him so I do what's called a pain science intervention. And I teach people a couple of different strategies during that intervention, which lowers the fear, lowers that harm alarm in the brain. And I give you a couple of simple exercises. And 2 days later, he emailed me. He said, I woke up this morning and it was like, poof, the pain was just gone. He's like, I had it last night when I went to bed. And all of a sudden, poof, it's just gone. I said, that's it. Your brain finally kind of reorganized itself and said, I don't need this anymore. It's not really serving me, basically.
Wow, that's really groundbreaking. That even that first part that you just said about how you turn down the harm alarm. I love that statement too. The harm alarm. That's powerful as well, because I resonate with that and sense it. I can feel what that feels like. Just bring our clients or our friends or whoever we're trying to help through this process to calm them down and help them to see more clearly. That alone can help them to make changes no matter what we're talking about. So with pain, I can see how that'd be really powerful.
Yeah.
So let's talk a little bit about, go ahead if you want to, go ahead. But I want to move into movement next too.
Yeah, I definitely want to give you a chance to ask more questions. There's something I think it's powerful to talk about with people. So the one group of people we have the most research on are those with fibromyalgia.
Yes.
And years ago, we thought that fibromyalgia was inflammatory related. We thought it was an autoimmune condition. We now know that's not what it is. It's what they call a pain processing disease. And oftentimes these are, a lot of times they're women who, when you look back at their history, they have some kind of trauma, whether it's emotional, psychological, physical. And that trauma, especially at an early age, when you have trauma at an early age, it really kind of rewires the brain. And that trauma causes chronic pain to develop, in that type of patient. So we know clearly that you actually don't have to have an injury or a physical injury, I should say. You can also have an emotional injury.
Okay.
And, let's say that emotional injury is someone abused me when I was, a young child. And now I have chronic pain from that. And the other interesting thing about that is we know that it ramps up the nervous system so much.
Mm-hmm.
Not only do you have pain, but you also have many other signs and symptoms. That's why when you see these patients or these clients, not only do they have chronic pain, but they've got, migraines, they've got gut issues. When we look at the patients with fibromyalgia, up in studies, upwards of 100% of them have gut issues.
Mm-hmm.
And you have to start to say to yourself, well, is it from the diet, or is it because the brain and gut are connected, and that's the connection there? It doesn't mean that you don't intervene with nutrition, because obviously if they're, eating a standard American diet, then there's a lot of things you can help them with. But it also means that you have to kind of help them out on different levels. And sometimes, and I have these patients, these fibromyalgia patients, come to me. I've been gluten-free for, gluten, dairy, sugar, soy-free for 20 years, and I still have gut problems. And I say, doesn't surprise me, because high cortisol levels, when you have stressful thoughts, those catastrophic thoughts, high cortisol levels causes intestinal permeability.
Yeah.
Causes.
Gosh, it's so connected. Everything is so connected.
Yeah.
Yeah. So interestingly, when you were just saying that about a minute ago about trauma, so I know that Nikki Gradix was on your Healing Pain Summit. I listened to her interview, which I was just blown away by, because I started researching the ACE, trauma and adverse childhood experiences, about a year and a half or two ago, just out of curiosity to see if maybe I had a couple clients that were just not able to move past the thought processes. And I thought there's something else going on here, because they've got it all together everywhere else. I thought that was really a great interview, and I shared it with my groups and shared her site as well. I like how she takes the ACE questionnaire and she takes it further and she adds on to it. I think that was really an important piece of why I like to read her information, is because it's not as simple as maybe Kaiser Permanente put together. I think it's a lot more complex. So tell me how trauma plays a part in the body. Is it cellular memory? Is it that the body doesn't know that trauma is now gone? I mean, how does that work together? Can you elaborate on that a little bit?
Yeah, it goes back to cortisol. High cortisol levels. Cortisol, as you know, does many things to the physical body. Puts weight on you, raises your blood sugar, causes blood pressure changes. But with the stress response, cortisol is extremely good at creating memories.
Really?
And it's important, because obviously, back in the day when we were cavemen, if that, let's pick something, that bush with the thorns on it, when you touch it, you now know that thorn is not only prickly, but if I touch that thorn, I'm going to get a allergic reaction to it. That's going to be with me for 2 weeks. So your brain remembers these things. It remembers the thorn, it remembers the color of the bush, it remembers, the environment around that bush, everything. Obviously, in our modern world, where we have these stresses, some of them are the little daily stresses we have, but obviously for someone who's had trauma, they start to get those memories stored as well. And there's like a priming of the brain and nervous system that starts to happen. And sometimes that priming can overflow or, kind of go into other parts of your memories where it really shouldn't be. And that's what's called a neurotag. So one part of the brain that stores that memory now starts to just interact with all other parts of the brain. And you have that stress response, and that pain response gets turned on with things that it really shouldn't. And that's why people with chronic pain say, I just walked 1 block, or I just went for a half a mile walk, and my pain, I shouldn't have pain from this. So they start to see that they have pain with things that don't kind of correlate.
Yeah.
And,
okay.
I don't know if that answers your question, but that's really the basis of it.
It does. That makes a lot of sense. I never thought about cortisol. I mean, I know that people say that it's your anti-inflammatory hormone, but it's also the other side of what you're saying. The other side of the coin is that it's also your inflammatory hormone, because it's creating memory. I've never thought about it like that. That's interesting. Yeah. Okay. So let's talk a little bit about when someone has fibromyalgia. I want to go back to that for just a moment, because it's such a common, I say symptom. I don't know. People call it a diagnosis, but to me, it's a symptom of something much bigger in the body. Something is happening underneath the surface causing that symptom. What are the steps that you take with someone that has fibromyalgia and has this belief that is an inflammatory problem? How do you not change their mind, but kind of change their mind, help them to see it differently?
I mean, and changing their mind is in some ways, you know, talking practitioner to practitioner is a great way to state it. Is you really need to spend time, and first of all, you have to really, really listen really closely during your initial intake and your assessment, as well as each visit, and listen to what they're saying and the things they believe in. If they start saying that, obviously, you know, my fibromyalgia pain is inflammatory and it's caused by gluten, you'd say, well, you may have a gluten intolerance, so let's take the gluten out. But once we've done that, if your pain is still, you know, persisting, we have to look at other places and listening to where the myths are about their body and pain, and kind of writing them down and saying, okay, I need to take someone through a little intervention. You know, it could be 10 to 30 minutes of just talking to them about that one thing, about how inflammation actually works in the body and how it's good sometimes, other times it's not good.
Right.
And in doing that, you'll decrease their fear. And I tell you, Carmen, most of it's about fear.
I agree. When
you talk to them about their activities, and you know, they say, well, I stopped cleaning my house because I'm in pain. And I say, why? And they say, well, every time I bent down to clean the toilet bowl or to do the laundry, I had pain. And I say, well, you know, a little bit of activity is actually good for you. So you're not doing any exercise, and actually housework can be a way to start some physical activity. Let's grade your activity. So let's just do a little bit. Maybe this week you just clean the guest bathroom that has one toilet bowl, and that's the only activity you do. And what you're doing is you're slowly reintroducing healthy activity into their life, and you're sending that message to the brain that they can do a little bit of activity, they can still be safe from it. If you know, we can't expect people are going to just listen to us and say, oh, it's from my brain. Oh, okay. That means I can go to CrossFit now.
Right.
You know, it doesn't work that way. This has to be slow and progressive and what's called graded on every level. So you have to look at their thoughts and grade how much they're working on as far as their thoughts. You have to grade their activity. Even diet. Like I have people come to me all the time asking me questions about oxalates and spinach and things like that. And I say, you know, honestly, if you don't have end-stage kidney disease or end-stage liver disease and you're relatively healthy, and those are easy tests, you don't even need functional medicine tests for those, then it's probably not the oxalates. But I ask people, I say, why oxalates? And they say, well, you know, I read this article online that says oxalates are like shards of glass running through your veins.
I've read that.
And I say, you know, that sounds terrifying to me. Because I would think if I had shards of glass, whether it was an inch long or whether it was microscopic, there'd be some kind of bleeding going on, and it'd be, you know, painful and awful. And wouldn't that happen all over my body, not just one area?
Right.
And then they start to say, oh, maybe. And what I tell them is, you know, if you're going to look at a plate of spinach every time you eat and be fearful of that plate of spinach, that could actually turn on your pain right there.
Yeah. Yeah.
And I go through this all the time with nutritionists because I'm a certified nutrition specialist and I've studied functional medicine. So I know about the nutrition parts of it. But I have nutritionists come to me like, I've tried everything. I've tried every nutritional approach and I still have chronic pain. I'm like, it's not your nutrition. Your diet's awesome. You know, put some spinach back in if you want, saute it or boil it or try to get some of the oxalates out of it. But that's not really the cause of your chronic pain. Okay.
I gotcha. Okay. So how can we even begin to help people shift in this direction besides the, you know, not even just people with fibromyalgia, but everyone? How can we move the mindset, move the needle just a little bit beyond having these conversations? You know, what are action steps that people can actually take to, I don't know, change their mind in a way that makes sense for them, because everyone's so different about what they believe, you know?
Right. You know, I think the main thing to do is, if you're a coach, a practitioner, that you have to really educate yourself about pain. I mean, I know physical therapists and, as I said, physicians that still don't understand the science, the science around pain is so extremely new and it's moving rapidly. Like, you think nutrition is moving rapidly, the pain science is moving super rapidly. Like, I spend every night probably 2 hours a night just reading about the pain science. So I really recommend picking up a copy of my book and going through some of the brain and pain chapters and just looking at some of the things that I've said in those chapters. And there's quizzes in there. There are, you know, tools you can download that you can use in your practice. And really understanding what pain is and what pain isn't, because until you understand it in yourself, it's really hard to start to work with patients. But working with patients to quiet their nervous system is number one. So your thoughts obviously are a big one. Meditation is another way to do that. Progressive relaxation is another way to do that. Tapping can even be a way to do that. And obviously when we talk about tapping, we're looking at tapping on certain parts of the body. And I want to talk about that in a minute. I want to do I want to screen share with everyone so that we can talk about that.
Yeah.
What else works for people? Any of the mind-body approaches that get you into relaxation. Restorative yoga is a great one if people aren't ready to move yet. All those things just help quiet that nervous system down. Once you quiet that nervous system down, then chronic pain starts to decrease. But the ultimate thing out of all those things, so, you can do some restorative yoga and it'll get you all, part of the way there. But unless you really work on your thought patterns, it's still not going to go away.
Yeah.
Can I do that screen share now?
Absolutely.
Is it good time?
Yeah, and then we'll hit some of the chat. I'm going to look at the chat box real quick while you get ready with that and find out if we've got some questions here.
So I want to share a little bit of the brain with people, so they really understand what's happening here. And
that's great.
Can you see that, Carmen?
Mm-hmm.
Can you see my cursor moving, or is that just me?
Yeah, I see your cursor moving. Mm-hmm.
Okay. So obviously, bottom left-hand corner here, this is the brain. In the brain, there's something called the somatosensory cortex. It's a little sliver. It's just above your ear, and it runs to the top of your head. This is a slice of that somatosensory cortex. In your brain, there's an actual representation of your entire body. It's like a map or a GPS. So there's a representation of your face and your head, your hand, obviously your arm, your torso, your back, your hips, all the way down to your foot.
Wow.
The cortical representation, or the amount of neurons in your brain that you have for the more sensitive parts of your body, i.e. your face and your hands, because that's where all your sensation comes in. Those are the five senses, is actually larger. And it should be that way because that's where that's where your brain picks up sensation. It picks up the information about the world around you. When you have chronic pain, so let's say you have chronic back pain. If you look at your back, it's actually represented quite small in the brain. Mm-hmm. Because honestly, it's not that important. Obviously, when I touch something that could be hot, this is a lot more important or sharp than this part. However, when you have that chronic pain, your brain starts to pay more attention to the parts that are painful. And this part that represents the back may actually get larger and or take over other cortical areas like the leg, foot or your calf. That's why people start with back pain. Mm-hmm. And they say, I had back pain. Now all of a sudden it's radiating into my buttock or it's radiating down my leg. And we start to, talk about like nerves radiating. Well, the truth is there are cortical changes happening in the brain that are causing that pain to kind of change, change direction, so to speak. And it's really interesting because a lot of times people with back pain or neck pain, they'll come in and they'll say, initially I had pain in the right side of my back, and now it's jumped over to the left side. I don't know why. Or I had pain in my neck, and now it's jumped down to my back. And we have done a really good job, like I said before, about looking at nerves and muscles, but ultimately it's the brain that is kind of changing. So this is a technical term we call smudging.
Okay.
So the brain likes things to be kind of neat and organized like a filing cabinet. So it knows exactly where your face is, it knows exactly where your hand is, it knows exactly where your back is. Smudging is when that back starts to take over the other cortical areas. So that's just a little kind of neuroscience about Pain 101. And if we take that person or that physical representation out of your brain and look at him or her, this is actually what your brain thinks your body is like.
Wow.
So obviously the hands, which are responsible for touch,
Yeah.
and the tongue and lips, obviously lips are very sensitive.
Mm-hmm.
And, your eyes are big because you have, visual input, and your nose. So obviously these parts are more highly represented and the other parts are not. However, when you have chronic pain, think if you have chronic back pain, the back would be very large. If you have chronic knee, the knee would be very large. So we do activities that kind of change that cortical representation and decrease that smudging, and refresh this whole GPS in your brain, if you will.
Oh, that's fascinating. I never knew that about now you hear about reflexology and how the entire body is represented in the foot, right? Like you can touch, a part of your foot and it represents your brain or whatever. I've never heard that about the brain. That's fascinating.
And that's also why, like EFT, why people find EFT or tapping to be so helpful, because your head is so highly represented. So if you have, let's say, pain in your shoulder,
Mm-hmm.
when I start, right now, if I have pain in my shoulder, my brain is constantly paying attention to my shoulder.
Yes.
What's going on? Where's the pain? Am I going to hurt myself? If I pick up that bag, it's heavy. What's it going to do to my shoulder? Can I lift weights? When you start doing that tapping, it starts to move the signals in my brain start to pay more attention to my head and less attention to that part of my body.
Okay.
That's also why massage works for some people, because
Mm-hmm.
I'm touching a part of your body that has been very sensitive. And as you touch it more and more, and I start to say, okay, you can touch it and I'm not feeling pain, you're that whole, it's called your homunculus, that little man in your brain, starts to refresh and starts to kind of repattern itself.
Okay. So maybe that's why when I did acupressure on my husband's hand the other night, his headache went away like within about 60 seconds.
That's it.
He was blown away. He was like, I don't know, you and all that hoodoo voodoo. I'm like, just humor me. Let me just press right here for a minute. And then he was like, I cannot believe this, but it's gone. I'm not going to admit this to anyone.
Most of the things that we have out there that we kind of look to that work, there's always a neurophysiological reason for why it works, basically.
Yeah. Okay. So let's take a moment because I see this chat box is lighting up over here. So I'm going to just throw a couple questions at you real quick.
Yeah.
First off, where can they find the questionnaire? You had said filling out that pain. I think she was talking about the catastrophizing. Are you that person that has the catastrophizing thoughts? Do you have a questionnaire for that? You had mentioned it earlier on.
The best questionnaire they can go to right now is I have a quiz. It's called The Pain Quiz. So thepainquiz.com.
Okay.
And that's the start of that questionnaire.
Okay.
There are some questionnaires in my book, and there are some questionnaires in my online program as well.
Okay, great. All right. So let's see here. What are your thoughts on helping people overcome pain after surgery, such as for joint replacement? Do you recommend, it says mediation, but I think they mean meditation, as a form of helping the mind control pain management?
Yeah, meditation, mindfulness-based stress reduction, it can be wonderful. The interesting thing about surgery, what we're finding out, is intervening with patients before they go into surgery and making sure their nervous system is as quiet as possible before they go into surgery is oftentimes the best way to prevent pain after surgery.
That's great.
Yeah. And we don't do that right now. Right now it's like, come to the OR at 5 a.m. in the morning and, you got this blue gown on you and a funny thing on your head and 6 people are around you. No one's introducing themselves. You're like, who is this? Who's cutting into me? Are they cutting into the right side half the time?
Well, they come at you with the marker and you're like, what are you going to do with that? And yeah, that's,
right.
You're exactly right. I mean, when I had a shoulder surgery last December, they told me the day that I'm laying there and they came at me with a needle, were you told you're having a nerve block in your neck? I'm like, I don't think so. No. And that just set me up. Like, I don't even know what that is. You're absolutely right about that.
So that's really the first step. So I say that for everyone on this call. So if they ever have surgery, and sometimes you need surgery for various things, not just orthopedic, it could be other things, is to try to go into that surgery as calm, as peaceful, and as quiet as possible. If you're coming out of surgery, if it's obviously an orthopedic surgery, then I really recommend every single patient start physical therapy. And it's not just for the strengthening and stretching component of it, like all that's wonderful. But when you start that little bit of movement right away, it sends that signal to the brain that I can move a little bit and still be safe.
Yeah.
So traditionally in physical therapy, we've looked at, structure and function and joints and muscles and, flexibility, and all that's great. And of course that's important, but ultimately we're learning that it really has an impact on the brain.
Yeah, that's great. Good point. I'm going to answer this question here. Carmen, do you always recommend that people always go on how they feel and ignore labs? No, I think just from my opinion that I think that we first and foremost, we tap into our instincts and intuition about how we're feeling. But labs can really help create a checklist for us to make sure, and sometimes even resolve fear that nothing serious is wrong. And that alone can help reduce pain, in my opinion. I know that was true for me and for many of my clients.
Yeah, that's right.
Yeah, and I always defer to the doctor, of course. If the doctor says you need labs, then you get the labs. We're not doctors. We're here to support that journey. So someone says here that Gabriella says, my mom has chronic joint pain and I don't believe I inherited it, but lately I do have pains. I'm wondering where it is coming from, not from her. But interesting that she brought her mom up first and then she mentioned herself. Do you have anything you want to say about that?
Well, it's funny. I have a patient in my online program, and she just posted a couple of weeks ago in the chat thread in the program, and she said she's had chronic back pain her entire life, and she said it wasn't until I realized about the brain and pain that I realized I thought back, and I have a disabled brother who has back pain, and my mom struggled with back pain, and she's like, my diet's perfect. I have an organic garden. I meditate. I exercise. She's like, it wasn't until I made that connection that maybe this is some kind of thought or held belief that I started to feel better. So again, that's that intervention. It's what they call a pain science intervention. It's just talking to people about some of these things can just open up a whole new world.
Yeah. I know that I had, when we had communicated by email at the end of the year last year, I had mentioned Dr. David Sarno or John Sarno and the divided mind. It was my first real introduction to the power of the brain, like talking to the body. But it was very hard for me to balance the thought that it's still a pain, right? It's not in my head. It's not just like psychosomatic, you're crazy. I mean, it really is something responding to your brain talking to you. And one of the things he had mentioned in that book was that if you stop moving your body, if you don't move, if you hold out and you don't do the things that you love to do, you're sending the message to the body that something is wrong. So what you were just saying a few minutes ago, that, venturing gently into movement can be really powerful for removing the belief that something is truly wrong.
Right.
So, and he's been around for decades. I mean, he won't even take clients anymore from what I understand. So you two would be a powerhouse together. Just saying. But
I know Dr. Sarno. He's actually here in New York City. I know him personally. He's probably about 93 years old now. What's interesting about his work was he started out really just looking at emotions. Mm-hmm. And emotions are huge to look at, but it's not the only thing as far as the thoughts. Emotions are just one part of it. So his work was groundbreaking. It was, probably in the 70s and 80s. Yes. And since then, we've moved, the science has moved so rapidly everywhere.
Yeah. I remember that part about the emotions. I was like, I'm not unhappy. And then I was like, maybe I am a little unhappy.
Right.
Okay. So we have a question from Gabriella. She says, how should we look at migraines? She has a teenage client that suffers from them. Wow. That's a big topic. Migraines are a big topic. Lots of people deal with that. Talk a little bit about migraines, if you don't mind.
Yeah. I mean, of course you can look to food first for migraines. You can look to, food sensitivities and some patients, I found that upwards of, 10 foods need to be eliminated before they actually feel better. But migraines also, we're looking and we're seeing that this kind of wave of depolarization happens throughout the entire brain with the migraine. Oftentimes stress related. People do really well with craniosacral for migraines, right? Or some kind of manual therapy intervention to their neck and head and spine. But it's all chronic pain really is the same. Yeah. Pain is the same, whether it's that ankle sprain or whether it's that chronic pain, obviously.
Right. Pain is pain, right?
Pain is pain.
Yeah. Right. So Lisa is saying she's a neurosurgery transcriptionist for 18 years and following everything you're saying. Had a single level ACDF-NP, I'm not sure what that is, 5 years ago, and keep up with my exercises and have no pain and never had it. But a surgeon said that pain can be like an alarm system that's turned off. The thief is in the house doing damage. What are your thoughts on that? She exercises but listens to her body and pulls back. knows when to pull back. Is that a subjective thing to be mindful and about your body and its signals?
So here's the pull back. I love the word pull back. And that goes back to the graded movement. So let's look at it like this. I'll use my arm. Can you see me? Which way is better? This way or this way?
That's good. Yep.
So let's say this is your pain barrier.
Okay.
So let's say you can walk a mile and you have no pain. But if you walk a mile and a quarter, you have pain. So every time you hit that mile and a quarter part, you stop. So the truth is you have to go just ever slightly into that pain, either every day or every week, whatever your program is. And then eventually your brain starts to say, okay, I can do this mile and a quarter now. It's okay. I was a little bit sore for 24 hours, but I'm safe.
Mm-hmm.
And then you can finally move to 1.5 miles and 2 miles. And you can use this graded approach to every single activity in your life, whether it's a daily activity, whether it's CrossFit, whether it's yoga, whatever it is.
Yeah.
But what happens with patients who have chronic pain is with the fear avoidance is they say, okay, I'm not going to walk a mile. And your brain says, okay, I'm going to back you up to a mile. And then they back up to a half a mile and then 10 blocks, and your brain just keeps backing you up basically. So you have to kind of start to just, venture forward into it. So I always say just a little bit into the soreness, not necessarily pain, just a little bit into the soreness and awareness. You're probably safe, but not necessarily pain.
Yeah, like conditioning. It's like an athlete training for a marathon. You don't go out and run 26 miles. You run a mile and then you work up. Yeah.
The other thing about exercise specifically, and actually every approach when it comes to pain, is that the brain likes very short, frequent doses of kind of this, healing we're talking about. So it's kind of like learning a language. You could take a beginner, French class at your local church, but if you go to France and you're immersed in it, and every day you're seeing a little bit of the signs and someone's talking to you and you're reading in the television, your brain picks it up a lot faster. So it's the same thing with chronic pain, that if you dose this frequently throughout the day in little bits, that neuroplasticity picks up and kicks in a lot faster.
Oh, that makes a lot of sense. So I'm going to look again. It's just blowing up, and I know, gosh, we could talk all day, and we do have a time limit here, but I want you to describe neuroplasticity a little bit. I know what it is, but I would love for you to share what it is. I mean, it's a word that's starting to make its way into our conversations in the coaching profession as well. So go ahead and describe that a little bit for us.
So neuroplasticity is the brain's ability to change, both in structure. So I showed you the kind of structure of the brain before, and it also changes in function, meaning neurotransmitters change. With people in pain, we talked about the structural part. The other part to talk about, just very briefly, are the neurotransmitters. And when you have chronic pain, what develops is what we call a dry brain. And what we mean by a dry brain is that the neurotransmitters that are responsible for pain modulation start to kind of dry up and go away. So those are serotonin, the dopamine. There are a lot of different neurotransmitters that are all responsible for this. So doing things to calm your thoughts, to do healthy movement, all that starts to turn on these natural opioids in your brain, and they trickle down from your brain to the rest of your nervous system, spinal cord, into your entire body. So the powerful take-home message is that you have a pharmacy in your brain, and you can turn that on. So that's the basics of neuroplasticity when it comes to the brain and pain, so to speak.
That's great. And I just want to make mention of this because that's a whole other topic, is neurotransmitters and pain. But you just did an interview with Beverly Meyer the other day, I just listened to the podcast, and I highly recommend people look into that as well. As even though, Trudy Scott, she works on the anxiety part. I mean, I'm just fascinated by all of the neurotransmitters and how our body responds to them in all ways. But I'm going to be sharing that information so that we don't have to go into it too much now. But let me ask you, I'm going to ask you one more question here from Pam. It's a little bit lengthy. I'm going to kind of brief it for you. She says she's had a number of surgeries, which she ultimately, trying to avoid a hysterectomy and so on. Since then has been diagnosed with a number of chronic pain conditions, autoimmune disorders, inflammatory processes, which she'd never heard of before. And then she goes on to state them. Could the immediate traumatic event have been that initial surgery that led to all of these problems that she seems to be having? She goes on about some other issues she's got going on, but thinks, is asking about that question and would like to not be on the multiple pain medications she takes. Could one thing set off a cascade in the whole body?
Sure. So earlier in the call, when I talked about those signs of danger,
yep.
So you can have either one really big sign of danger. Let's say you had that diagnosis of an autoimmune disease, and it sets you off into a whole stress response.
Mm-hmm.
Or you can have little small signs of danger. So the small signs of danger is I'm working 10 hours a day, and my husband doesn't help. It's Christmas, and I have to hang out with my in-laws. I don't like them. My diet is poor. I'm not getting enough sleep. Those are all little signs of danger.
Right.
Or you have that one big sign of danger. So the answer to our question is yes. And surgery in particular, what people don't realize is surgery is a trauma to the body.
Mm-hmm.
And that's why I always tell people, like, if you can stay out of surgery, it's one of the best things you can do is make it a last resort.
Yeah. I 100% agree with that. Unfortunately, I've had too many and wish I didn't hit that last resort area for so long. But I wanted to make one comment about the EMDR real quick because I have had the EMDR, and I like to do a lot of that little hacking stuff to try things and see what they're like. And I thought it was really fascinating that I was a little skeptical, just a touch. And the person that was doing it, she is the master EMDR person here in Nashville, Tennessee. And what she did was she had me recall an incident that was very strong in my mind that I could almost feel the feelings of it. And I pulled up my son T-boning his head into a metal beam, right? When he was 3 years old. It went all the way down to the bone. And I remembered really going into that masculine energy, picking up, running, looking at it. I could bring it all into my mind, how deep the cut was and so on. So we did the session around that. And fast forward, at the end of it, she asked me, what does it look like now? What does the wound look like now? And I'm like, I can't even bring it to my mind.
Right.
And I still haven't been able to. I was blown away, completely blown away about how my brain was rewired to forget that incident in such a traumatic way. It is now gone from my memory.
I'll give you a quick little hack that's similar to EMDR, and people can try this if they have chronic pain. And I have another podcast I have to talk on, so hop off. But if you take both your hands with your thumb like this in front of you, I'll do it to the side.
Yep.
And with your eyes, you focus on your thumbs.
Okay.
And you turn your head and you go like this. Back and forth, nice and slowly, and then rapidly start to increase it. It's a little bit similar to an EMDR technique, and it'll start to kind of refresh that homunculus in your brain. And you can do that a couple times a day. It's a quick little hack that you might find helps with people's pain.
Awesome. That's great. What a great tip. This has been really helpful. And I mean, I'm almost feeling selfish right now because I got so much out of this just for me. So I'm really excited about your book, and I just want to encourage everyone to check it out. I will be sharing all of the information so people can go directly to, it's not out yet, right? Because it hasn't shown up on my Kindle yet.
It's not out yet. So it'll be, I think it's on Kindle the last week of January, and then February 7th. It's in stores, but buy it now. It's 40% off, and it's only like $10.
Yeah,
it's a great deal. So the book is called Heal Your Pain Now.
Yep. The
Revolutionary Program to Reset Your Brain and Body for a Pain-Free Life. You can find it on Amazon and all the major online retailers. You can also go to my website at drjoetatta.com and find it. And you can also go to thepainquiz.com. It's a great place to check it out. So Carmen, your team, your tribe is awesome. I love their questions.
They've got great questions. And I also want to throw one more thing in is this is a great book to gift to clients. So if you have clients that are struggling with this is a wonderful thank you for working with me type of gift. Always refer to our experts. And thank you again, Joe. I appreciate it. And I hope to see you maybe next year at Mindshare or this year at Mindshare. Will you be there this year?
I'll be there.
All right. I'll see you there. Thanks so much again. Have a great day. Thanks. Bye, everybody.